Today's lecture is about culture and health. So let's get started. By way of an overview, we will begin by defining both culture and health, followed by a description of how the two terms intersect. We'll then shift to presenting strategies for obtaining cultural information, describe the continuum of cultural competence, and end with conclusions. So let's begin. There are a variety of different definitions for culture. Admittedly, it is one of those concepts that we are pretty sure that we understand, but when asked to provide a definition, it can be a bit challenging because as a concept for many of us, it just is. That said, here's one definition that I'd like to use as a way to ground us all in a common understanding of the term. According to Edberg, culture is defined as differences in the way people look, act, talk, and carry out their daily lives that are more than individual differences, but common to some group and distinct from our own group. Some elements of the definition that I'd like to bring to your attention include the parts highlighted. So, culture is embodied by the way people look, act, talk, and carry out daily lives, and they are also common to certain groups, yet distinct from our own group. As we consider this definition, how do you think stereotypes play a role? And do you think there's some superficiality associated with this perspective? More about both of these questions later. What we find in the literature is, despite the origins of the disciplines such as anthropology, biology, social science, etc., there are a number of commonalities that we should draw in the variety of definitions that exist for culture. First, culture is learned. That is, it is typically passed down from one generation to another. Secondly, culture is cumulative. That is, culture is comprised by the sum of our experiences. Third, culture is normative. That is, for the group for which the culture is ascribed, the beliefs, actions, attitudes, etc. that comprise culture is what is normal, quote, for that group. And fourth, culture affects how we view the world, others, family, and relationships. More about this later. Another important aspect of culture is describing what determines it. I'd like you to take a moment to jot down your ideas before I reveal my answers. So oftentimes when we think of culture, things like religion, what one believes or doesn't believe related to a higher power, region, that is where one resides or grew up, social class, such as divisions based on social and economic status, ethnicity, which is based on common national or ethnic traditions, and perhaps gender. And by gender here, I'm referencing socially constructed definitions of what it is to be male or female, rather than biology per se. It is likely that some of our characteristics overlapped, but you may also have others that you wrote down as well. All of these different characteristics work together to formulate what we recognize as one's culture. An important question that I also want to raise is, who determines the culture of society? Oftentimes, we may take for granted that the people, quote, determine culture, but I want to push you to think a bit deeper about that. How does power play a role? Is it that those with the most power in a society determine the societal culture? Is it those with the loudest voices? How about the people with the purse strings, although they all too often are the ones with the power as well? Or how about the majority? Do they determine culture? I encourage you to think about your answers to this question as we proceed through the lecture. This image depicts an important perspective about culture. What you see here is that culture can be divided into what is called surface culture and deep culture. As you see, surface culture includes those aspects of culture that most readily rise to the surface, pun intended, to describe culture. Examples include food, festivals, right? Who doesn't love a good cultural festival for its food? Arts and crafts, fashion, and language, to name a few. But then at a deeper level, there is deep culture. Examples that characterize deep culture include communication styles and rules, such as certain gestures, whether or not eye contact is a sign of respect and tone of voice, attitudes toward elders, adolescence and about death, and approaches to things like courtship, marriage, decision making, and problem solving. So, while we often feel that we just happen to know what culture is, perhaps on a superficial level, once we dive more deeply, yep, another pun, we see a whole host of other characteristics that comprise culture. In an earlier slide, I asked how stereotypes might be related to how we understand culture. So let's explore that a bit more. The process of stereotyping is described as assigning individuals to categories based on what's believed about the general group that they belong to. The problem with stereotypes is that they are usually based on limited personal knowledge and/or experiences. So if, for instance, one's exposure to Southern culture is limited to media portrayals or folks speaking with a Southern drawl, only drinking sweet tea and wearing corsets, a la Gone with the Wind, that could be their assumption of all Southerners. Rather, cultural factors should serve as guidelines and insights to assist in understanding other people. One presenter that I've seen who illustrates this perspective really well is named Chimamanda Ngozi Adichie. She did a TED Talk entitled The Danger of a Single Story. I'll ask you to take a look at her presentation to help provide additional context to how stereotypes emerge and can be very limiting. So now let's shift to health. Health is yet another concept that we have working definitions for, but for the sake of commonality, let's establish our own understanding. Health by the World Health Organization is defined as a state of complete physical, mental, and social well-being, and not merely the absence of infirmity. Now that we have a common understanding about the definition, would you say that there are any cultural nuances to this definition? Well, yes, there are. Think about being large or overweight, or some might say obese, for a moment. In some cultures, having more meat on the bones is a sign of wealth or prosperity or fertility, whereas being thin can be associated with illness or poor quality of life. Also, what it means to be balanced in all aspects of one's life as a sign of health, or viewing health as part of a collective. That is, if my group or my collective is not healthy, then I am not healthy. So, what is the public health relevance of the association between culture and health? Notions of culture and health can affect how we interact and what the components of health promotion programs, for example, can or should be. More about that as we proceed through the lecture and the rest of this course. So, here is a list of 5 principles for thinking about the intersection of culture and health in practice. First, it is important to understand that every person has health knowledge and practices that should be acknowledged. They may be different from our own, or we may not believe in them, but we should acknowledge that they exist. Secondly, it is common for people to have more than one system of health knowledge. For example, one may live in the U.S. and perhaps have a Western perspective about medical intervention and health, but perhaps also has cultural ties and Eastern philosophies of wellness and prevention. Third, culture and health can be impacted by a myriad of contexts, including environmental, social, structural, political, and economic factors. Fourth, to maximize health outcomes for a given project or person, one should take time to learn about the systems of health knowledge and practice that exist and work with them to solve health problems. This is particularly important because it is often easy to dismiss a perspective as minimal or insignificant if it is not in line with the dominant culture or perspective. This principle is suggesting that we find ways to integrate all perspectives. And fifth, take time to understand what cultural factors may impact the health issue and whether or how those factors can be addressed in an intervention. Oftentimes, you'll work best by including members of the population with which you're working to be sure to honor their perspectives. Now, let's shift gears to discussing how we obtain cultural information. Key strategies for obtaining cultural information include, as I just mentioned, developing partnerships with people and organizations. There are several instances from my own work when I've done this. One project involved conducting a community-based participatory research project to examine the long-term impact of a technological disaster, formerly termed man-made disaster, on the health of community residents in Graniteville, South Carolina. A second project involved examining the feasibility of a mobile technology approach to unintended pregnancy prevention among African American 18 to 19-year-olds in South Carolina. And a third project involved examining tobacco use among youth in a southern rural middle school, and this one was in rural Mississippi. For each of these projects, can you suggest some of the partnerships that I should forge to maximize an understanding of culture? For example, for Graniteville, I developed a community advisory board comprised of community residents of different ages, races, and ethnicities, socioeconomic statuses, faith traditions, etc., in order to obtain the full scope of cultures present in the community. For the African American Youth Project, I enlisted the youth themselves in addition to youth stakeholders such as parents, teachers, and health educators. For the Tobacco Project, we worked with the youth as well as school administrators. These projects were certainly enriched by the relationships and partnerships built to help us in working alongside cultural norms that we may not have been privy to otherwise as, quote, outsiders to the communities. As it relates to the collection of cultural information, once we establish these partnerships, qualitative rather than quantitative data is the preferred method. Let's explore that a bit. There are a number of different reasons why qualitative approaches are preferred in helping to understand culture. First, in order to collect data about culture, one should know what they're asking for, which can actually be difficult in the beginning of trying to capture cultural meanings. Secondly, it is difficult to capture these meanings by using closed-ended questions, which are found in quantitative rather than qualitative assessments. And third, understanding culture involves the way in which behavior is shaped and understood within systems of meaning, which are often subjective and interpretive and most easily answered via qualitative assessments. Here are several examples of data collection methods and their characteristics. Most people, research savvy or not, have heard of focus groups. Focus groups are discussion-based and include a trained moderator to facilitate discussion, standardized discussion guide, and a carefully planned recruitment strategy. Typically, these are conducted at a facility with some level of privacy so that discussions cannot be overheard by others not involved in the project or discussion, and some recording devices used to document the discussion. This is a qualitative method. Next are interviews. These are typically performed one-on-one with a trained interviewer and interviewee with, again, a standardized discussion guide to elicit the same information from each individual. An interview that is unstructured and allows for the participant to respond to open-ended questions and elaborate on responses is an example of a qualitative method. We also have nominal group technique. This approach is less popular but can be likened to a focus group with an element of prioritizing and ranking. This approach can address a limitation of focus groups whereby one or two people can dominate a discussion. Nominal groups ensure balanced participation because all participants rank and prioritize responses to questions compiled by the group. We could argue that nominal groups are qualitative and quantitative in nature. And surveys. Surveys are conducted with a clearly defined population, are theoretically sound, valid, and reliable, and can consist of both open-ended or qualitative questions as well as closed-ended or quantitative questions. Now, let's test your knowledge. Review these descriptions and determine if it is a description of qualitative or quantitative data. Now, for these descriptions or terms, determine if the data are obtained qualitatively or quantitatively. Our final concept for this lecture is the continuum of cultural competence. Let's start by defining cultural competence. You sense a trend here? According to the Office of Minority Health Resources Center, cultural competence is a set of congruent behaviors, knowledge, attitudes, and policies that come together in a system, organization, or among professionals that enables effective work in cross-cultural situations. More practically speaking, according to Dr. Udo, a global leadership development expert, to be culturally competent doesn't mean you're an authority in the values and beliefs of every culture. What it does mean is that you hold a deep respect for cultural differences and are eager to learn and willing to accept that there are many ways of viewing the world. Key elements of this explanation are having a deep respect for difference, an eagerness to learn, and a willingness to accept different perspectives rather than striving to be an authority in all cultures, beliefs, and practices. This description embodies an emerging term that we see in the literature called cultural humility. Take a moment to view this image. As you do, there are a few things that I'd like to point out. First, this image depicts cultural competence as part of a larger continuum of cultural awareness that begins with cultural destructiveness and peaks at cultural proficiency. Of note is that when we refer to cultural competence, most people consider this as an optimal level of cultural awareness and/or understanding, and as you can see here, cultural proficiency is one step beyond achieving cultural competence. Also of note is that this understanding is linear with an upward trajectory. Again, here, the understanding is that we can rise to the occasion of cultural competence and ultimately cultural proficiency. We should also recognize that someone can begin at a lower level, such as cultural destructiveness, and ascend to proficiency. Also, take note of the other stages of cultural proficiency along the continuum. Now that we have a common understanding of cultural competence, let's discuss why it is important to be culturally competent. One reason is to respond to current and projected demographic changes. The U.S. is projected to become a majority-minority nation as early as the year 2030. That is, what are now described as racial and ethnic minorities will comprise more than 50% of the U.S. population. Thus, the culture of what may be considered as others or minorities will be the culture of more than half of our population. Secondly, being culturally competent is important to help optimize patient-provider relations. A third reason to be culturally competent is to aid in eliminating health disparities. And a final reason to be culturally competent is to aid in working effectively in a global context. Keep in mind that working in a global context is not limited to those who choose to work internationally. Given that our nation has been founded by and is comprised of peoples from diverse heritages and cultures, this notion applies to us all. With that said, here are some barriers to cultural competence that we should acknowledge. These include lack of knowledge, lack of cultural encounters, that is, if we're limited to interacting with people with the same cultural views as our own, self-protection or denial, which is best explained by the next barrier, that being fear of the new or unknown. Similarly, fear of changing, and finally, pressure due to time constraints, perhaps in the healthcare or public health intervention environment. Understanding that these barriers exist and perhaps even anticipating that they may occur will aid in developing strategies to address them should they arise. Can you think of any strategies for addressing any of these barriers to cultural competence in your own current or future profession as a public health practitioner? There are a number of specific strategies that can be used in a variety of different disciplines to aid in becoming culturally competent, and as we now know, rising to the optimal level of cultural understanding, which is cultural proficiency. The slides that follow include some of these strategies. Admittedly, they are designed for those working in healthcare settings, but I see them as widely applicable. So, for example, you might ask yourself, who are my patients, families, and coworkers with whom I work? How can I learn about them? And what are my beliefs about this group? When you interact with someone and want to improve in your cultural awareness, ask them questions, listen to their responses, and be aware of language nuances and communication styles. Here are some ideas about how to be sensitive to another person's personal health beliefs and practices. Here are some suggestions about how to be sensitive to language barriers. You may need to consider religious or spiritual factors, such as these. Body language is also an important communication tool, so here are some cues to consider, as well as additional cultural factors that may not readily come to mind. Then, finally, here are 10 practical ways to facilitate communication across cultural boundaries. Take a moment to review this list. Have you employed any of these strategies in your own work environments? Do you have some ideas about how you could employ these strategies in the future? In conclusion, while we have a core understanding of culture, I have acknowledged that there are a variety of definitions that exist with important basic components among them. Also, it is important to understand that we similarly established a core definition for health, but that different cultures can define health differently as well. I introduced the continuum of cultural competence, some strategies to facilitate communication across cultural boundaries. And finally, it is important to note that we can use knowledge of culture to help improve health outcomes and work to eliminate health disparities. Lastly, these are the correct responses to the questions about qualitative versus quantitative data. And these are the correct responses to how data are obtained. See you next lecture.